Thank you, Brian. So first, I really want to congratulate KCRS for this amazing meeting. And we're excited to have this new session. And as you just heard, these are the 3 abstracts that were highest ranked among all those that have been submitted. So what we're going to do is have a full presentation of each of them, about 12 minutes, and then we'll have 7 minutes of Q&A. So be ready. We'll have the microphones, they've been checked all across the room so that you can ask questions to our speakers. And so without further ado, on behalf of my co-moderators, David McDermott, I'm delighted to ask Professor Tom Pauls from Barts, coming from London, to give us his presentation entitled Pembrolizumab plus belzutifan versus pembrolizumab plus placebo as adjuvant therapy for RCC. And these are the PROs of the LightSpark 022. Tom, please.
Thank you. Thank you, Laurence. This picture here was painted 250 years ago. It's no coincidence. It coincides with your independence. It's actually a picture. You'll see the guy in the middle in white. He's dying there. His name's Lord Chatham. He was giving a talk in the House of Lords, and he found out in the middle of the talk that America had declared independence. And he had an immediate heart attack, and sadly he died. So independence didn't work out well for everyone. It certainly didn't for Lord Chatham and his family. Here's a picture of me during the vigil that takes place every year. During the there are not many in this picture here, but there were others during this vigil. Whether they were actually just taking part in the museum, wandering around, I don't know. But perhaps a moment's silence with the permission of Tony and the...
You're running out of time.
A moment's silence. A moment's silence for the family of Lord Chatham would be fabulous at the beginning of my talk. I'm grateful. I'm Tom Pauls. Congratulations on your 250 years, by the way. Okay, so I'm really delighted to be here. There are no more jokes in my talk. I'm really delighted to be here today talking about quality of life. It's something I think about quite a lot. And I think it's something which is evolving, and I'm very happy to answer any questions around this. This is a randomized phase 3 study of pembrolizumab and belzutifan versus pembrolizumab and placebo in the adjuvant setting. It's LightSpark 22. Tony presented the original data. It's published in the New England Journal of Medicine. We've not seen this quality of life data before. I think it's important, and we'll discuss, or we'll raise a number of points which we can discuss. I think it's fair to say that LightSpark 22 was a groundbreaking study for a number of reasons. A positive combination in the adjuvant setting, number one. Disease-free survival, which was statistically significant. I think it's also clinically meaningful. Overall survival wasn't achieved. I genuinely believe this is immature overall survival in the same way as the original data cuts of 564 were immature, and we wait for mature OS data. I think it's a regime which is attractive, and I also think it's important because for me the VEGF TKI studies were negative in this space for this, or were almost all negative. This was a positive trial, and for me it suggests that belzutifan is distinct from the VEGF TKIs, and I think that's an important issue. We've not shown the quality of life data before. We're going to do that for you right now. You'll know the trial. It's an enormous study of nearly 2,000 patients. It's the same population as 564. As I mentioned before, it hit its endpoints. 28 months follow-up is actually quite short for a survival signal. Many in the audience may also feel it's short for quality of life, and that's something I'm happy to chat about. The secondary PRO outcomes I'm going to try and explain to you today, if I am able to, in a concise and coherent way. We essentially looked at 3 different scores. FKSI 19, there are subsets of that, which I'm going to talk about. There's disease-related symptoms. Now you might say to me, Tom, these patients are in the adjuvant setting, why are you measuring disease-related symptoms? I'll come to that in a second. The EORTC QOQ30C, that's the classic questionnaire, and you can break that down into 7 or 8 subsets. We're going to show 3 of those subsets. And then something new that you might not have seen before, which is the GP5 score, where you basically ask questions, ask patients how much they're bothered by their side effects. I think that's actually a good question for quality of life of cancer drugs, and perhaps sometimes asking people about financial toxicity or whether they've got pain passing urine maybe that's less useful. I think we probably need to ask simpler questions, in my opinion. And while we describe these questionnaires as being validated, they're certainly not validated for immune therapy or belzutifan in this particular setting, and that needs to be considered as a potential shortcoming. This is the progression-free survival, or this is the disease-free survival. You've seen this before. That's not updated, of course. And I think it's reasonable also to show you the safety results that we have of this. One needs to put safety and quality of life hand in hand. And as you can see here, there are more adverse events associated with the combination, more grade 3 or more adverse events. And these are those adverse events. I think it's important, in my opinion, to recognise that immune checkpoint inhibition is associated with, at times, life-changing and long-term toxicity, where these drugs, these oral drugs, belzutifan, is associated with fatigue and anemia, but much of that is transient and occurs while the patient is having therapy. And in my opinion, these are unlikely to result in long-term effects on quality of life. I think when you stop the drug, the fatigue gets better and the anemia kind of goes away. So there is an issue, particularly in the adjuvant setting, where patients want 20, 30 years of life, which is different from the metastatic setting, around quality of life. And while patients are on therapy, I think inevitably, to some extent, people will be prepared to pay a price for long-term survival and long-term outcome, where in the metastatic setting, particularly in the palliative setting, things are different. This highlights an important point, in my opinion, in that we tend to bulge everything together in quality of life. I think we should be looking at the adjuvant setting for long-term outcomes, different from the metastatic setting, particularly when life expectancy can be short. In this PRO assessment, we had 3 phases. We had the on-treatment phase during the year of therapy. We then had the end of treatment, we had a discontinuation quality of life questionnaire. And then from there, we went on essentially looking for 3 years of follow-up. I think it's also fair to say that we looked at the least square of means. That's essentially, it's pulling the data together and making a mean score for all of those 900 patients. So you get a single data point, which is accessible, but within that, there'll be a great deal of variability. So that's mostly what I'm going to show you today. Also, because after 84 weeks, our compliance dropped, we pre-specified that we would be looking at compliance above 60%. So that's why we picked that 84-week mark. But I will also show you the longer-term data, but you'll see the confidence intervals getting wider and wider under those circumstances. I'm going to give you a little bit of details now about these 3 questionnaires. I talked about disease-related symptoms before. There's statistical significance and there's clinically meaningful data in quality of life. And again, I'm very happy to have this debate. With a 900-patient trial in both arms, 1,800 patients, you're going to hit statistical significance in a binary test. So, 1 is going to be different from 2, even very minor differences in a 1,000-patient trial, 2,000-patient trial. But that doesn't necessarily mean it's statistically significant, and their thresholds of statistical significance have been met. Now, again, these are the same in the adjuvant and the metastatic setting, and I'm not sure we have explored these as robustly as we might, but for what it's worth, these are the levels which are given, and I will show them on the Kaplan-Meier curves, which I show you today. As I said before, disease-related symptoms at the top, they're mainly cancer symptoms. QLQ30, we're looking at 2 of those QLQ, or 3 of those QLQ30 scores. We're looking at the global health score, which I think is a great score in my opinion, but others disagree. And we're looking at the physical score and the role functional score. So physical, are you able to get up and down stairs? Role functional, are you able to do your job? Those are the questions. Now, role functional, clearly really important in the adjuvant setting because we want our patients to be able to function and will continue to function during this period of time. So I think that EORTC QLQ30 is probably the most important for me. And I said before, the one you might not be familiar with at the end, around the 5-point scale of were you bothered by the side effects of treatment. Well, I'm going to show you the difference between completion and compliance. There is a difference between these 2. I'm going to show you both terms. I wanted to explain them to you before I show you them. Completion essentially is the denominator is the whole PRO population. Compliance is that population, but we exclude those patients who have died or progressed or are no longer on trial. So slightly different forms of analysis. And here you can see the compliance and completion scores. And then you can see at 84 weeks, those drop down essentially to that 60% level, which I talked about before. Almost everyone clearly is having it at baseline, but at 84 weeks, we're dropping down to about 60%. That's actually pretty good for a quality of life questionnaire, for what it's worth. And here's the first data analysis. So this is the least square of mean analysis. This is for disease-related symptoms. You might say, well, these are adjuvant patients, they're not going to relapse, they shouldn't have disease-related symptoms. Actually, I think you'll find potentially things like anemia or fatigue are going to have disease-related symptoms. There's a huge overlap between our cancer drugs and our cancer symptoms. And again, that's a big shortcoming of looking at broad things like fatigue. As you can see, none of these two at baseline and at week 84 hit that clinically meaningful change associated with the reduction. And then you can look at it over time. This is a different way of looking at it. I actually prefer doing it this way for what it's worth. I think it's more informative. And you can see during the period of therapy, the green line might be dropping slightly below the red line. But you can see they come back together pretty quickly once therapy stops. I think that's meaningful, and I think you can say to patients you're giving this combination, yeah, you might feel a little bit more tired in the combination, but when it stops, it goes away quite quickly. That's different from immune checkpoint inhibition, where you have to say to patients, there's a 1 in 10 chance you might need long-term steroids, you might get diabetes, you might get heart problems and neurological problems, and it may be in 10 years' time you're still struggling from that. And for me, that's quite an important concept, because from a patient's perspective, the reversibility, in my opinion, is potentially attractive. I think these are the scores which I talked about. This is the global health score. For what it's worth, this is a score which I think is pretty accurate. Again, some of the points, particularly during that therapy period, are statistically below but not clinically meaningful for the combination, bouncing back to normal. And then physical function and role function. Physical, getting upstairs would be an example. Role function, are you able to go to work? Essentially very similar findings. I would describe these, in my opinion, as pretty consistent findings. And then, of course, as you can see, when you get to 144 weeks, you can see those confidence intervals become super wide. The data becomes less accurate. Some patients, of course, did hit those clinically meaningful levels of either an improvement or deterioration. It's a minority, because they've got to hit those 7-point change or that 3-point change. Not many patients achieve that. You can see it's as a proportion, it's about 10 to 15%. Not enormously different in the two arms. And then just at the end, are you bothered by the side effects of treatment? Not at all, up to very much. And patients just filling out a questionnaire, marking it out of 5. Let's keep it really simple. And I quite like this. And I don't think we've shown quality of life in this way before. You can see across the time points, you get some indication of what's happening between the two. I draw your attention to the grey and the black quality bars, and because those are significant issues. And you can see actually between the two, not an enormous difference, in my opinion, between those. What does this tell us? Well, I think it tells us a couple of things. The majority of patients are able to tolerate this therapy, and as I said before, I think particularly from a belzutifan perspective, that's reversible. So I've described at the beginning of this that we showed a significant difference between the addition of belzutifan and placebo added to pembrolizumab in this large, robust adjuvant trial with immature overall survival. I think we also showed you fairly consistent patterns across different quality of life tools, both looking at the least square of means and with time, the decrease and the increase, and that last scoring system, the GB5 score, are you bothered by treatment? I think that issue around looking at quality of life differently is something that we as a group need to explore moving forward. I think at times we are doing our best with these tools, but I think there are ways of improving them, and I'm sure we'll talk about those in a moment. I think together, in my opinion, what this tells us is that the quality of life data is in line with the toxicity data. There is more fatigue, we know about that, and more anemia. That may be associated with a temporary but reversible small decrease in quality of life, but it doesn't hit those clinically meaningful levels. And of course, when you stop the drug, it seems to go away. Many thanks for your attention. Congratulations on your independence.
This is open for questions. Any questions for Dr. Powles? Just raise your hand and the microphone will find you. While we wait for questions to emerge, there's one over here. There we go.
I really liked the way you presented the "Are you bothered by the side effect" analysis. That does seem new and important at a high level. I do think it's, these patients though are going to be our most motivated patients who are most willing to encounter toxicity by enrolling in this sort of trial. So I do wonder how a group of people in the real world who have not chosen to enroll in a phase 3 placebo-controlled randomized trial might experience the same physical symptom, because I've had patients who were excited they got anemic because they thought that meant they were on belzutifan. And that's just not going to be the patient, the average patient. So I'm just wondering, when you think about applying these results from a trial population to a clinic discussion with a normal patient or a patient who's not in a trial, how you would think about doing that?
Well, firstly, thank you for your question. I try to visit the real world as infrequently as possible. But when I am there, I think it is fair to say that the translation between clinical trial data and wider forums is not 100% translation. You're absolutely right, these patients are excited. We screened more patients, many didn't take part, and we don't track those patients who we didn't screen and take part in the trial. I think we do have opportunities to, moving forward, look at real-world quality of life data. Some of the things we're doing at our site is we're using wearable devices in the adjuvant setting to see what happens to step count and sleeping patterns when patients start adjuvant therapy. I think we also need to be, in my opinion, moving away from some of these very rigid time points on quality of life and getting real-time feedback from patients on their quality of life. We're not doing that very well at the moment. I think this is useful data because it gives us broad indications of, is there a clear and dangerous signal on quality of life? And the answer to that question, in my opinion, is no. But do we have a good indication of what's really happening in the long term or on a day-to-day basis? And the answer to that question is also no.
Other questions?
Here to the right.
We have one. We have another microphone on this side, I think.
Can I?
Yep.
Can I
Go for it.
Yep. Go ahead.
Keep talking. It's gonna work. Keep talking.
Who's your right patient to give adjuvant pembrolizumab?
So I'm going to answer this question directly, and not everyone's going to agree with me. I was involved with the trial, and there's a conflict of interest associated with that. But I'm involved in lots of different trials, and so I've got so many conflicts. I hope I end up being conflictedly balanced, if that's a phrase that's widely used. I don't know. I personally feel this way, that I think the decision to have immune checkpoint inhibition in the adjuvant setting is quite a big decision. I think there is a chance of getting long-term toxicity associated with immune checkpoint inhibition. And I think all of us have seen that in our clinics, and I think anyone who hasn't yet treated enough patients. And when it happens and you lose a patient, or a patient comes into harm's way or ends up in intensive care, we all know, we remember that in the adjuvant setting. And that is something which sticks in all of our minds. Having said that, pembrolizumab is associated with a clear survival benefit in this setting, and I think patients need to know that. And I also know for sure that dying of kidney cancer is a pretty bad outcome, and that has to be put in context. And for that reason, I'm a fan of adjuvant pembrolizumab. I offer it to all my patients, but probably I offer it to all my patients. We have a discussion about the balance of what I just said, and I think about 66% of patients take it up from our perspective. There are some patients I might not offer it to, those with multiple comorbidities, multiple problems, and who've just about got through the operation. And I might not offer it to 10, 15%. I might even have a conversation. You know, an 85-year-old individual with performance status of 2 who's struggling to get out of bed, I'm not going to be offering it to that individual. The addition of belzutifan, from my perspective, assuming we put money to one side and we put availability to one side, from my perspective, I don't see this as a huge leap on top of that. You can start the drug, you can give the drug, and you can stop it quite quickly. The side effects, I think, are not long-term, not life-threatening, and quite reversible. So I am more relaxed from a therapy perspective about adding in that second drug. Now, don't get me wrong, there are side effects associated with that, and that discussion needs to take place. But because I believe those side effects are potentially reversible, and I think there is clear significance in terms of the delay in disease-free survival, and we do not yet have that OS signal, which, by the way, is important to me. I've been very consistent that OS is important in the adjuvant setting, and that will continue. I give this combination, would give it the benefit of the doubt and say you can have the addition of the second drug, it will reduce the risk of the cancer coming back, and although there are more side effects, we can stop the drug, we can stop it after 1 month if we have to. So that's my position. I do podcasts with a friend of mine called Brian Rennie. He's a slightly different position.
Okay, I think we have maybe one quick question in the front there.
And quick
Thank
answer.
you so much for the talk. I think one of the downside of Keynote 564 is that even without the treatment, 80% of patients are with kind of no evidence of disease. So I'm just curious to what, if you look at the patient outcome data, to what extent it is acceptable to increase the intensity of the treatment for these favorable the risk of the relapse. So.
If I may, I'm going to try and, because I did the best I could. Your suggestion is within the population of the trial, there are different risk groups, and those at lower risk, the benefit might be less, although in the forest plot the benefit is the same from a hazard ratio perspective, because that group's inherently at lower risk, the absolute benefit becomes more narrow. And then your question, I think, correct me if I'm wrong, is in that group where the risk-benefit ratio, the benefit is lower, is the risk the same or worthwhile? And the answer to your question is yes, the risk is the same across all groups of patients. And as you go into a lower and lower risk group, inevitably that balance, that ratio of risk-benefit is going to move from benefiting in the highest risk group, clear giving therapy, to the lowest risk group, perhaps a balance between the two. And again, I think that's a clinical decision with you and the patients. I think they need to know the absolute survival benefit associated with pembrolizumab, and they need to know the absolute DFS benefit associated with this combination with belzutifan and the fact it doesn't yet have overall survival, and put those in context with the risk of side effects. And again, describing those side effects differently. Immune checkpoint inhibition with perhaps longer term side effects, belzutifan perhaps with more reversible side effects, but perhaps more immediate, particularly around that anemia and fatigue which we talked about. I hope that vaguely answers your question.
Okay, before the timekeeper turns into Lord Chatham, let's go to the next speaker.
And so we're pleased to welcome Dr. James Jones from University of Cambridge to present relationship between plasma KIM1 levels, peripheral immune profiles, and disease-free survival outcomes within the TRANSFER-MPART study.
Thanks, Laurence. Thank you. So I'm James Jones. I'm from Cambridge. And yeah, really excited to be here today to talk to you about some of our data on KIM1 from the TRANSFER-MPART study. I'm trying to work out how this works. Does that advance it, or does that work? Ah, that works. Brilliant. Okay. So a bit of background, some repetition here. I think we're all aware that adjuvant pembrolizumab is really the mainstay of care in the management of post-operative kidney cancer. But there have been some mixed results in this space, so a number of negative trials. But then progress in the last 12 months, of course with LIGHTSPARK-022 showing a DFS benefit, as we've just heard, and the RAMPART study, which showed DFS benefit for the combination of adjuvant durvalumab plus tremelimumab, although interestingly not for the durvalumab monotherapy arm. But as we just heard, immunotherapy is associated with significant toxicities. Again, just thinking of some of my own patients who've had bad toxicity from adjuvant pembro, and we're conscious that not everyone benefits. So it's a risk reduction. There are numbers needed to treat. So improving patient selection is really a key research question. As is understanding the complexity of the differences between these agents in the adjuvant setting. So KIM1 has had a lot of interest, and it's shown promise as both a prognostic and a predictive marker. So this is a transmembrane glycoprotein that's produced into the blood in kidney injury and in kidney cancer, and there's evidence both in early and advanced kidney cancer that it might be useful. So the Rampart study, it was an international randomized phase 3 trial, and it enrolled patients with kidney cancer who were either intermediate or high risk of relapse, and that used the Leibovitz score to stratify the randomization. And it included, interestingly, both clear cell and non-clear cell patients. And in total, the trial randomized 790 patients in a 3:2:2 ratio to either active monitoring, which was arm A, durvalumab monotherapy, anti-PD-L1 drug, or durvalumab plus tremelimumab, so a CTLA-4 as well. And I should say that Rampart actually stopped early, of course, because adjuvant pembrolizumab became standard care, so it was no longer appropriate to enroll people into the active monitoring arm. So just to remind us of the results of Rampart, so this is the graph that was shown by James Larkin at ASCO a couple of months ago. So this shows the DFS outcomes. So visually quite similar between the two intervention arms. But if we look at the DFS results, it was actually only durvalumab plus tremelimumab that reached statistical significance for DFS, and the durvalumab monotherapy missed statistical significance. Okay, so going on to Trans-Rampart then. So Trans-Rampart was the translational study that was run alongside Rampart in the UK, and 187 patients were enrolled in parallel to the main study. And so these patients had prospective longitudinal sample collection, initially at baseline, and then at various time points in the first year of treatment, and then we've also been following them out to 5 years and to relapse. Patients had blood and urine collected, and the collection was actually tiered based on what the sites could do, so you could be sort of a gold tier club member, if you like, and they could do everything, whereas the smaller centres maybe only did certain aspects, and they were sort of silver and bronze level. And so in this analysis, we've run the plasma by an MSD cytokine array for a focused immune panel and also for KIM1. And we've also worked with a company in London called IMU Biosciences, who developed this high-resolution flow cytometry platform to look at the PBMCs on the study. So looking at the population characteristics for KIM1, so we had baseline levels available for 119 of the patients, with a sex ratio that we expected for a kidney cancer population, of course, being more common in males. And of those, 100 of them had clear cell, 19 had non-clear cell. And for a KIM1 high threshold, so this has been said at different levels by different groups, but we chose to use the 86 picograms per mil threshold that was reported by the Emotion 010 group in the publication from 2025. So what did we see? Well, we saw that KIM1 high patients tended to be a little bit older. We didn't see any sex differences, but then looking at the different risk groups, we did see that a higher fraction of the high Leibovitz score patients were KIM1 high, as maybe you might expect. But then interestingly, actually, we didn't get very many N1 NED that were KIM1 high, but the numbers are very small there. So moving on to the results. So first we looked at what the effect of your KIM1 status was within each arm of the trial. So looking at the active monitoring arm, KIM1 high patients had significantly worse DFS than KIM1 low patients. So that reproduces findings reported elsewhere. But then when you add in immunotherapy, you no longer see this DFS difference either with monotherapy or with the combination therapy, suggesting that immunotherapy is affecting the outcome, I guess, for the KIM1 high patients. So we didn't see this prognostic effect in the intervention arms. We then went on to look at looking at the data a different way, looking at the treatment effect in either the KIM1 high or the KIM1 low subgroup. So firstly, looking at the durvalumab treated patients, KIM1 high, we did see a DFS benefit for durvalumab in the KIM1 high patients. But then for durvalumab KIM1 low, no DFS benefit observed. Then moving on to the combination therapy arm, again KIM1 high trend, but not significant DFS benefit for the combination. And again with KIM1 low, no benefit from adjuvant therapy. We've then done some early work on looking at the immune profile, because I guess the suggestion here is, well, if there's some interaction between your KIM1 status and the effect of immunotherapy, maybe there are immune differences in the patients. So looking at the cytokine profile, we've seen some subtle differences. So in the panel, we saw significantly high levels of CCL3 in the KIM1 high patients, which is a sort of myeloid recruiting cytokine, and also an IL-12, of course, associated with the T-cell response. And I've not plotted the data here, but if you then look longitudinally, we actually see that those differences in CCL3 and IL-12 actually sort of strengthen in the KIM1 high group when they're treated with durvalumab plus tremelimumab. Then looking at the PBMC profile, we actually don't really see any clear differences in the PBMCs that we're confident in reporting at the moment. So we've just presented an overview here. So looking at the PCA of the whole PBMC analysis, we don't see much of a split between KIM1 high and KIM1 low groups at baseline. And again, we don't see any clear differences in cell set enrichment, so immune cells that might be higher or lower in KIM1 high patients. Although I should say that the analysis is very small and possibly underpowered for that analysis. Okay, so to summarise the findings, so high KIM1 levels were prognostic for worse DFS in active monitoring. That reproduces things that have been seen previously. But that negative prognostic effect of KIM1 isn't seen when patients were treated with immunotherapy. High KIM1 did seem to be predictive of benefit from durvalumab monotherapy, but we didn't see a clear benefit of adjuvant therapy for patients who had low KIM1 levels. There might be some subtle immune differences between KIM1 high and KIM1 low patients, and that's something we're looking at further. But I should say that this is a small exploratory analysis, and so it limits our ability to make firm conclusions. But I do think that it adds the evidence that KIM1 is useful in selected patients for adjuvant therapy, and that as a field we should be looking at this further. So just to acknowledge key contributors, so Grant Stewart, who's at the back somewhere, who led this work, the UMVI team in Cambridge who delivered the study, and then from the Early Cancer Institute, Rebecca Ray, who's one of our PhD students who've done a lot of the analysis, reported here. We've had great input from the Manifest Consortium in the UK, IMU Biosciences who did the PBMCs, and of course the Rampart group, particularly Angela, Tom and James Larkin. Thanks so much for listening, and happy to take any questions, and thanks to the organisers for the opportunity to present.
So, terrific presentation, James. Questions, please raise your hand and we'll send you a microphone. Right down in front there. Let's see.
Yes, most patients that have kidney cancer also have some underlying chronic kidney disease. Studies correcting for their underlying chronic kidney disease, which can also contribute to KIM1 levels.
Yes, that's a great question. So I think we need to do more work on defining what the right levels of KIM1 are and translating to disease. So this threshold, we mirrored what was in the international alone, but if you look at static predictive setting, the levels are completely different, so much higher, and as you say, 5.2%. So I think we need to do more work on that to understand what the right levels are and use as a diagnostic threshold.
Microphone to Vincent.
Congratulations on kind of a great study, and I'm really gratified to see sort of adjuvant IO treatment selection for KIM1 kind of panning out in another trial, obviously closely mirroring the Motion 10 data which Laurence initially presented. So my question is about just logistically, the company that ran the KIM1 assay using MSD, which I agree, mesoscale discovery is the correct platform to use. Logistically, if someone in Europe wanted to use that company to run KIM1 samples from another trial, are they commercially running this assay? And is this a way that we can get research KIM1 done in Europe?
Yeah, so thanks, Vincent, and thanks as well for all your input and discussions on this past couple of months. It's been really helpful. So we run the assay in Cambridge in our core facility. So they purchased the MSD assay, and we run it in-house. And certainly for UK sites, we could run potentially the assay at our place in Cambridge if it's sent to us. I mean, having had some conversations with the MSD reps, I think they've also talked about having blood sent to them to run the assay as well. And this is also something that we've talked about with the Manifest Consortium, which is this immunotherapy response consortium that runs in the UK, initially via Cambridge using our core facility, but then potentially actually directly through MSD. But no, I mean, we could run it locally in Cambridge if needed.
Thank you. And I guess one more question was, Rampart was a very large study. Trans-Rampart was smaller. Did you already all the samples available, and samples you run, additional plasma available for analyses potentially?
Yeah, so unfortunately we have run everything. We've run all the patients that we have because we only got a subset in Trans-Rampart, which is a limitation. But we do have additional plasma banks that we didn't run through the assay.
Okay, thank you.
Other questions? Just raise your hand. So James, your last bullet was about future directions. So if money was, well, maybe not. What would be the trial you would want to propose in the adjuvant setting that might help confirm the value of this, and how would we fund such a trial?
So I think I guess I'd say two things. I think we need to do a little bit more work on what the thresholds would be for that study.
Right.
So I don't think we completely nailed down things like the levels. So, for example, in Rampart, this level was taken right before they had the dose of adjuvant therapy. But in the clinic, we're actually using. We're making that decision maybe at week 6, week 8, not at week 13 or week 12.
Mm-hmm.
So we may need to do a little bit more work on actually what the cutoff is.
Mm-hmm.
I think if we establish that, then you could think about doing a prospective study where you stratify patients to adjuvant therapy or observation based on KIM1 status. I guess the question would be, can you de-escalate KIM1 low patients?
Right.
Which we could discuss. Are we there yet? When pembrolizumab is so established, I don't know, but I think it's something we should be talking about as a field.
What about treating patients who would not be eligible for pembro based on 564 but are KIM1 high?
That's an interesting question.
Well, that's the disadvantage of finishing your talk quickly, is you open yourself up for questions. Unlike some of us who went on forever.
I mean, I normally do put art history in my talks, actually, but I'm cutting out this time. So I think that we should look at, so clearly some of the patients that were KIM1 high were Leibovitch intermediate from the data that we've shown. So the enrollment criteria for Rampart and KidneyCAN are not the same, so it's difficult to, off the top of my head, think how they would correspond.
Mm-hmm.
I don't know, it's difficult, isn't it? Because we've talked about the risks of giving treatment, and is KIM1 the real driver of what's going on, or is actually your TNM status the right marker? I don't know.
Okay.
Would you put someone who was relatively a Leibovitch 4 if they had KIM1 high? I don't know. It's hard though. That's a good question.
Other questions from the audience? All right.
James, it does seem madness that we're still using TNM staging to define patients at risk of relapse, because clearly there's biologically some tumours that can grow to be really, really big and they're not very aggressive, and that's why they become really, really big and then patients aren't in harm's way. And there's another group of patients that have small aggressive tumours and they intend to, coming to what David said, there's a group that just is going to do badly biologically. In kidney cancer, we've got tumour-based biomarkers, and now we seem to have moved into an era of ctDNA, and there was that presentation at ASCO, and now there's KIM1, which may define risk. Do we need to use biology and circulating biomarkers to supersede this TNM Leibovitch thing altogether? Do you see that happening in the future? So that's my first question. And then my second question is, KIM1's kind of stuck. You can't improve KIM1 a bit, you could maybe improve it, but you measure it, it's there or it's not. Where you could, in the future, improve ctDNA analysis. We could get deeper, we could use whole genome analysis rather. Is the future actually, is it going to end up by, although KIM1 seems to have got to a great start compared to ctDNA, in the end ctDNA is going to take over because we will be able to do deeper analysis, and KIM1 is going to end up on sort of the cutting room floor industry.
Oh, well, thanks, Tom. So the first question is, what should we supersede TNM? Well, I guess we use TNM for a reason because it's the key driver of survival. I think if we look at what other tumour sites have achieved, most other cancers use TNM to make peri-surgical decisions. In some cancers, maybe breast, you've got things like Optima, where they use some RNA profiling to refine the decision, but it's still being driven by the stage, really. So, maybe it could be used as a refining strategy. I'm trying to think what other tumours like PSA and prostate, that's used a little bit for risk stratification, isn't it, in localised setting, I guess, where they treat prostate. But really, most cancers, TNM is the driver for the decision making, isn't it? So I think it's part of the toolbox, but maybe it's not the single part of the decision. And then, KIM1 versus ctDNA. I'm not sort of wedded to KIM1. I'm interested in it, but we should use the best test. I think the advantages of KIM1, though, are that it's easy to assay, it's relatively stable, and things that have sort of made it to clinic are readily assayed in blood and can be rolled out to different centres, and I guess KIM1 fulfills that in a way that maybe ctDNA requires more specialist equipment at the moment. So, and also potentially is tumour informed. In terms of other ways that we could improve to KIM1, I think you could also look at the dynamic levels. I think looking at things like what the pre and the post-op KIM1 change might be interesting. The relative change within patients, or even that kinetics post-op might be interesting as well. So I think there's more to do there.
Thank you, James. Thank you very much. And so without further ado, we're moving now to Dr. Raina McKay, coming from UCSD, and she will be presenting safety profile of casdatifan single agent in patient with clear cell RCC, the pool analysis of ARC-20 study. Raina.
Wonderful. Thank you so much for the introduction and for allowing me to present this data on behalf of all of our co-authors. Here are my disclosures. We'll start out in true ASCO fashion, I guess. These are our key takeaways. The safety profile for casdatifan was consistent with that of the therapeutic class. Anemia and hypoxia, both of which are on-target AEs, were manageable, enabling patients to remain on therapy, and the use of ESAs did not negatively impact our RPFS. As you all know, HIF-2 alpha is a key driver in the development and progression of clear cell RCC, and casdatifan is a potent and selective HIF-2 alpha inhibitor, which has been shown to be associated with deep and sustained EPO suppression, that of which has been associated and correlated with response. The ARC-20 is a phase 1 dose escalation, dose expansion study of casdatifan that enrolled multiple cohorts. For the purpose of this talk, we're going to be focusing on the casdatifan monotherapy cohorts in dose expansion with a key look at the 100 milligram daily dose, which is the recommended phase 3 dose. This puts us at 127 patients in the pooled analysis. These are all patients that have been IO exposed and VEGF exposed, and they were HIF-2 alpha inhibitor naive. Here are the baseline characteristics for the patients that were enrolled. This was really a treatment refractory population encompassing patients that had intermediate and poor risk disease, and the median number of lines of prior therapy was 3. 31% of patients had baseline liver metastases, and the entry hemoglobin for these patients had a median of 12.3. The safety profile of casdatifan was that was consistent with the therapeutic class, and when we look at the treatment-related adverse events, namely the grade 3 or higher events, they were at 49%. But I think what's important is to look at the rates of treatment discontinuation were really quite low across the cohort at 3% and 3% in what is the recommended phase 3 dose moving forward. We're going to do a deep dive into the AEs of special interest and the treatment-related AEs. On this slide, you can see that grade 3 and 4 treatment-related AEs were mainly anemia and hypoxia. The rate of any grade anemia was at 89% in the pooled analysis, and 40% grade 3-4 events. And if you look at hypoxia, 16% for any grade and 10% for grade 3 and 4 in the pooled population. We also looked at the time to onset of the adverse events and looked at that in the pooled population and also the 100 milligram Q daily dose. And I think this is instructive also for clinical practice, that the time of onset is actually early. The median time of anemia was at 27 days. The median time for hypoxia was at 32 days, that you can see referenced here. With regards to the treatment-related anemia, none led to casdatifan discontinuation, and you can see the profile of how the anemia was managed with regards to the dosing of the casdatifan here, which was reassuring to see. And the median relative dose intensity in the pooled cohort was at 97.7 milligrams, and if we look at the pooled or the median relative dose intensity of the 100 milligram cohort, understanding that the pooled population had a mixture of different doses, it was at 92%, so greater than 90% dose intensity that we can see at the 100 milligram dose. I think a lot of anemia is around how do we manage this clinically in the clinic, what are we doing, ESAs, transfusions, and so forth. So 70% of anemia was actually managed with additional therapeutics. 40% of individuals received an ESA only, 14% received a blood transfusion only, and the combination was at 16%. The median time to onset of ESA use was at 64 days. And the median number of blood transfusions was about 2 per patient. So we wanted to put this up there not to necessarily compare the two cohorts here. So the dotted line that you see is just the PFS of the pooled population, which is at 12.2 months. And again, this is not for comparison, but rather to look at the group that received an ESA. What was the PFS of that group? You know, there's been historic data about the use of growth factors in oncology and, you know, kind of a dissuasion about their use, particularly around the ESAs. But in fact, we do not see a decrement in the PFS. It's at 19.2 months. And if you look at the beginning portion of the curve and the median time, you could say, oh, well, there's a time bias associated with the ESA use, but in fact, it's not. You see the curves are actually overlapping in the beginning portion of those curves. Again, not to compare, but just as a point of reference that, you know, are we harming patients with use of ESA? And I don't think so. Now we're going to shift gears and talk about the hypoxia. The grade 3 and 4 hypoxia occurred in approximately 10% of patients at the 100 milligram dose with very low rates of treatment discontinuation, less than 3% that you can see delineated here. And again, we put up the median relative dose intensity as a frame of reference here. So with regards to how the hypoxia was managed, and these numbers are only for the patients that actually experienced hypoxia. So they look a little bit inflated at first glance, but it's only in the individuals who had hypoxia. So 70% of individuals were actually treated with oxygen therapy, and the median time to use was at 26 days. Median duration of use was around 1 month, 25 days, and time to resolution was around 11 days. And the median time to onset of the first grade 3 hypoxic event was at 22 days. So I think, you know, what this impresses upon me is that these events actually happen really quite early. When you have a patient that's coming in to the clinic, you know, being mindful of monitoring for these events. So to take us back to our key takeaways, I won't reiterate this. I think these are what we expect to see with casdatifan as a HIF-2 alpha inhibitor. This is on-target effects, and I think we need to think about how we manage these patients, as there are multiple HIF-2 alpha inhibitors in the clinic, certainly belzutifan that's already being utilized. And I think it's important that we have a good treatment algorithm around this. So the next couple of slides, actually 2 slides, are going to be presented from a manuscript that's currently under revisions at Lancet Oncology on the monitoring and management of AEs. And I definitely want to give a shout out to Dr. Ayana Kaman, I'm sorry, I always mispronounce it, and Yue Chen and Brad McGregor, who have been really instrumental in helping us develop this manuscript that hopefully will be published in the near future. But we put together some treatment algorithms around anemia management, and more so as an approach to somebody that's starting a HIF-2 alpha inhibitor. What should you be doing at baseline? What are things to check for? And management of mild, moderate anemia. These are our own personal kind of as patients, as people who, clinicians who have taken care of a lot of patients that have received HIF-2 alpha inhibitors, what's the appropriate approach? And so this is the algorithm for anemia, and this is also the algorithm for hypoxia. And I think having a good frame of reference that can be referenced very easily about what to do and how to manage, I think is really important. So you can feel free to use these tools, and hopefully they'll be published for your access in the near future. And that segues us into the PEAK-1 study that's currently actually actively enrolling patients of casdatifan plus cabozantinib versus placebo cabozantinib in the second-line setting. And you can access the QR code and the trial in progress poster. We're excited about this trial. And we thank all of those individuals or all those sites that are enrolling for PEAK. You can see them here, all the different countries across the globe. And if you have any questions, feel free to ask. Thank you all.
So thank you, Dr. McKay. Another very efficient talk.
Question? Penalized for this.
Yes, he will suffer. Questions from the audience? So while
Mike. I don't know if this is on. Okay.
Yep.
So Raina, nice talk. Question is, how much hypoxia have you seen in the absence of anemia, and can one control hypoxia by keeping hemoglobin above a certain level in patients?
Very good question, and actually there's probably an analysis worth seeing. I think a lot of times they do happen concurrently because the rates of any grade anemia are at 80%, and so the rates of hypoxia are actually less than that. I think the proportion of patients that are having hypoxia without any anemia are actually exceedingly low.
And can you manage hypoxia, future episodes of hypoxia, therefore, by keeping someone's hemoglobin above 10 or whatever for their particular needs by giving EPO?
Absolutely. I mean, I think in my clinical practice, my approach is if I'm putting in a prescription for a HIF-2 alpha inhibitor, I'm actually putting in the prior auth the day I write the prescription for the HIF-2 alpha inhibitor for the ESA. Because as you've seen, these declines happen pretty quickly, and they happen within the first month. And unless you're actually checking their labs and having the, proactivity to do something about it, you're going to run into trouble. The last thing you want to do is put somebody on a HIF-2 alpha inhibitor, have them see you in a month, their hemoglobin drops from 11 to 9, nothing happens about it, you haven't done anything for and then they come in 1 month and they've got a hemoglobin of 7 and they're in distress. So I think being acutely on top of it is really key, and I think at baseline, checking for iron, B12, reversing iron deficiency with IV iron, not waiting around for oral iron to do its thing, I think is really important. And these are things in my practice that I have implemented to really help patients have a better experience.
I think it's important to treat anemia aggressively. So I always try to keep them around 10, but I have not seen that the hypoxia can go away if you overcome the anemia. To me, they are dissociated. Two different phenomena, they operate independently in my experience. The only thing that has helped, at least in bezutifan, I don't have experience with casdatifan, has been dose reduction on the bezutifan in some patients. But that can become a real problem with the oxygen, and that has not resolved with anemia treatment.
So,
Bill? I agree, anemia of a level of 5-6 can have a pulse ox 100%. You still carry oxygen fine even with low hemoglobin. They're not, associated. I think we can look forward to seeing this publication to see what you think about managing anemia and hypoxia, and hopefully we'll have consensus and an easy path because we proved that these are on target.
Billy has a question over there on the left.
I know you told us not to compare the ESA use Kaplan-Meier curves, but comparing them in a positive way, do you think that the fact that the patients who've got ESAs are doing better, is it all just a biomarker of, like a pharmacodynamic biomarker of on-target engagement? So if you did the same analysis with anemia, is probably not fair, but hypoxia, would you see the same thing where patients who were on a certain level of oxygen also did better?
Yeah, I I mean, I do think it's a pharmacodynamic readout of the activity of the drug. It's almost very similar to what we've seen with VEGF inhibition and hypertension, you know, so I do think that there is a correlation. I don't think that there's like a time bias with our ESA analysis because I think these drugs were used pretty early on, right around the time of the first scan assessment that's actually taking place. I think with hypoxia it's a little bit more challenging because there can be other comorbidities or other things that come into play in that group of patients.
Dr. Brugarolas in the back, I think, has a question.
So with respect to a comment and a question, or actually, well, so I'll start with the first. So, I mean, obviously, EPO is a pharmacodynamic marker, but it's not going to account for HIF-2-dependent biology. So, in other words, if EPO is not suppressed, it's unlikely that the drug is going to have an effect. But if EPO is suppressed, only those tumors that are HIF-2-dependent will respond. With respect to the hypoxia, I was recently in Europe. Somebody made the argument, I mean, for my patients, when they go on belzutifan, I recommend they get a pulse ox and they monitor their oxygen. But somebody said, I mean, are you going to do anything with somebody that has an oxygen saturation of 88% or 87% if they are asymptomatic? So I don't know that we really know what it means to have some level of hypoxia, and I don't know at what point it makes sense to intervene.
The patient physically actually looks okay, but the nurse is driving you in, their pulse ox is reading blah, blah, blah. You're like, something's wrong with the pulse ox. No, there's got to be. So in my experience, it's a rare situation where somebody is coming in using their accessory muscles to breathe and manifesting legitimate shortness of breath. So I agree with you that it's a struggle. Like, do you check, do you not check? You almost want those patients to have a little bit of supplemental O2 at home. That's where we run into trouble because when you overexert somebody at risk, then they do become symptomatic and that becomes a problem.
I mean, I think to me, the situation here would be to try to figure out when is hypoxia symptomatic. I mean, do we need to worry about the patients that have underlying severe COPD and emphysema or cardiovascular disease? So, I mean, many patients, if it's just slightly reduced oxygen saturation, maybe it's not even worth monitoring. So I wonder whether there would be the opportunity.
You gotta look at Tom and embed in the questionnaires, do you feel short of breath? And ask it to the patients on a regular basis. Like, I don't even think that question actually is in any of those tools.
Right.
Because I think it's a very different, and when do you feel short of breath if you do?
Agreed.
Other questions from the audience? So, Raina, if you were imagining a phase 3 trial that was casdatifan versus HIF inhibitor X, X, for now, it's HIF inhibitor X. If this drug was more effective, more efficacy, would you also see more toxicity?
It's hard to know. I think potentially, but could there be a saturation effect with the tox that you're going to see? I think there's a learning curve. I think also with the management of these side effects, we saw it with IV treatments as they rolled out. There was more tox at the beginning because we didn't know what we were doing, and then we learned how to treat it. So my hope is actually we learn how to use HIF-2 alpha inhibitors better in the clinic and mitigate tox for all patients.
Well, then, to that point, though, should we be using the McKay criteria for belzutifan now?
It's a framework and a guide because one doesn't exist. It's not spelled out in the NCCN guidelines. It's not in the ASCO guidelines. I think there's a lot of now, community use of these agents, and I think if you're not using them left and right in the clinic and really have developed an eye for when these things happen, I think people can run into trouble, and if they have a bad experience, that can impact how people utilize it was.
But just to be clear, you think there might be a chance of separating on-target efficacy and toxicity?
Potentially.
Okay.
Thank you very much. So we're going to wrap up this session. I need to stress that we're on time despite having Professor Pauls on the panel. So that's amazing. And I'm handing over back to Brian.
Thanks, everybody. Time for some caffeine.